Hello everyone, we are going to see the topic that is called as a adenomyosis. So before starting with the concept of adenomyosis, first we should know what are the basic layers of the uterus. So in uterus there are three layers that is inside of the endometrium, middle one that is the myometrium and outside that is the perimetrium. So if endometrium grows inside of the myometrium, then it is called as a adenomyosis. That is the basic concept of it. We are going to see what is the definition of it. So if you see the definition point of view, what is it? It is a benign growth of what? Of endometrium, where it takes place into the myometrium. What is myometrium? It is the middle layer of the uterus. And what is which sort of? It is both inwards, that is the stroma is also inward, and the glandular part is also inward in it. And the next question, so why this is happening? The etiology, it is unknown to this. So that is the basic concept that is related with that of the adenomyosis. It is a benign ingrowth of endometrium into the myometrium, both glandular and stroma. It is inward, and the etiology, it is unknown. So next question arises: if you see in this diagram, this is a normal one. What are the layers inside of the endometrium, myometrium, and perimetrium? And while in adenomyosis, what we are going to see? So this is the cyst which is formed. Endometrium growth inside of the myometrium. So that is the basic concept of adenomyosis. So next, what is the pathology related with that of? So what happened over here? So uterus get enlarged, that is myometrial hyperplasia. And how is the enlargement of it is? It is not a symmetrical enlargement. So it is how can say that? So if the uterus, we imagine this is the part of the uterus, this is the fundus of it, cervix and the vagina. So when the uterus is, it is equally enlarged, but in case of adenomyosis, mostly the back part, that is the posterior part, it is get enlarged and it is asymmetrical. One part remains the same, but the one part it is get enlarged more. So that is the pathology where it takes place and how much it is size. So whatever, if the gravid uterus, that is the pregnant uterus, if it is becomes up to the for 12 to 14 weeks, that much size it is increased. So that is the concept, that is pathology of it. And if you see on the cut section, if you see the cut section, so whatever the wall of the uterus, it becomes the thick wall which is characterized by presence of trabeculated appearance without any capsule. So that is related with that of pathology of the adenomyosis. It is enlargement, asymmetrical, size up to 12 to 14 weeks, and on cut section it becomes thick and without any capsule. So that is related with that of pathology. If you say this is the grossly appearance, how this one. So there is a thickened hyperplasia. So what we see in this diagram, let's see how it is. It becomes the thick one, and if you see this, if compare one side, it is more of enlarged as compared to, so that is why it is asymmetrical enlargement, what we are going to see in the adenomyosis. And myometrium, that is what we are going to see, the thick part of it is, that is the presentation of the adenomyosis. And if you see the microscopically the glandular tissues, these are surrounded by the stromal cells in the myometrium, and the ectopic endometrium separate from the whatever the ectopic what which the present in between this, it is separated from the basal and endometrium which is underlying, and it is located deeper in the endometrial junction by more than 1 hpf, and response to the steroids, it is minimal invasion mainly in the basal layer. So that is the microscopically what we are going to say. This is the diagram that what we are going to say. Just see this in between, that is adenomyosis. Let's see. And how the clinically, that is a question arises in our mind. If we see the clinical point of view, which type of which age group that is the affected over here? So it is commonly affected after the age of means after the age of 40 years, that is near about some menopause age group, and the parents, that is who has given the birth to the child. And it is most of the times Most of the it is the asymptomatic, and if it is the symptoms are present, then it is related after the age of some 40 years with Paris woman. And it is not known that patient come from the any complaints accidentally. Patient do the any routine examination, and that during that routine examination the adenomyosis gets find out. And most of the it is along with that, it is not the single, most of the it is coexisted with that of endometriosis and the uterine fibroid. So what is endometriosis? It is the presence of functioning endometrium other than the normal side, that is called as the endometriosis, and the fibroid, that is a benign growth that is coexist. It is mostly it is present, that is clinical features. So usually asymptomatic, detected on routine examination, Paris near their 40s, and with endometriosis and fibroid that is coexist with it. So symptom wise, there is a menorrhagia. Why? If you think about it, menorrhagia means if the cycle is normal, but there is an excess of bleeding in duration or in quantity, or both the ways, that more than 80 ml and more than about 5 to 7 days, where or in both the combination can be present over here. So why menorrhagia? In the adenomyosis problem, for normal menstrual cycle, there is maybe normal HPO axis, that is hypothalamus pituitary ovarian axis. So here there is no problem with that of the hypothalamus, no problem with that of pituitary gland, no problem with that of ovary. The cycle is going to be normal. So duration, the female, how it is going to present it, she is going to say that the menstrual cycle it is normal, but there is an excess of the bleeding or excess of the duration, or both the things can be present. The reason behind it, why there is a bleeding is more because of increase in the surface area. But obvious in the normal and in the this one in adenomyosis, the surface area is more, so it leads to that of more of discharge. If you see in the diagram point of view, and then congestive dysmenorrhea, that is cramping with menstrual flow or days earlier, or some cramps throughout the month aggravating during the period, and deep dysmenorrhea premenstrually. So if you want to see from this diagram, just see whatever the discharge from this endometrium, it is going to be normal, but surface area of this is more than the normal. That's why the duration it is, or quantity it is more. That's why there is a menorrhagia. There is no problem with that of HPOA axis, that is hypothalamus pituitary ovarian axis is normal. So cycle is going to be normal over here, and when it is going to contract for that during the menstruation, so it is going to compress it, and it leads to the dysmenorrhea. That is the common presentation can be present. And science wise, it is an abdominal examination. If you do the abdominal examination, uterus it is enlarged, and how much it is, not more than up to 14 weeks, means it is definitely goes the more than the pubic symphysis. And how is the, if you do the pelvic examination, why this is more than pubic symphysis? Because during pregnant gravid uterus up to the pubic symphysis, the height of the uterus is 12 weeks, so it is more than the pubic symphysis, but just less than the 14 weeks. Pelvic examination, it is a uniform uterine enlargement with no restriction of mobility. If do the vaginal examination, the uterine, there is no restriction for the mobility, but uterus it is enlarged. Uterus may be softer than the normal, that is filled consistency, and finding altered if there is associated with endometriosis. And if endometriosis is there, the symptoms are present of that of endometriosis, that is cyclical presentation everywhere, that we know that in endometriosis. And if you do the investigation ultrasound, so what we are going to say, it is an enlarged uterus, and how it is asymmetrical enlargement, mostly on the posterior wall. And myometrium, it is multiple cysts are going to be seen, increased vascularity, heterogeneous texture, and that of endometrial junction intestines. So if localized, misdiagnosed for the fibroids, sometimes it may happen that we think about it is a fibroid, but it is actually adenomyosis. So that may be presentation. Just see in this diagram, in the ultrasonography, this is the endometrium. This is presence myometrium, and where there is a presence of this endometrial tissue. That is what we are going to see this diagram. This, it is seen under the sonography is like this. This, how it is, this is black spots, what we are going to say it, that is adenomyosis. So that is the concept related with that of, and if we are going to do it, the MRI we are going to do it. In MRI there may be presence of increase in the posterior wall, there is present, and if you are going to do the treatment point of it, so we have to think about first if there is a, if, most of the cases asymptomatic, and if the symptoms are present, then for the dysmenorrhea we can think about the non-steroidal anti-inflammatory drug, oral contraceptive pills. And if age, if the patient is of some age more than 40 years, so we can think about the hysterectomy, that is total hysterectomy we can think about. But if the age is not that, that is if the fertility patient want to survive, if it is local part it is affected, at that moment we are thinking about the preserving of this uterus. So that is in short concept of the adenomyosis. Thank you very much.